and welcome to Hospice Insights, the Law and Beyond, where we connect you to what matters in the ever-changing world of hospice and palliative care. Behind the curtain, enhanced provider enrollment oversight. Adam, I'm so glad you're here because I can't keep track of all these things that keep happening and coming out. And so I appreciate you joining to talk about all these new enrollment things.
Yeah, thank you, Megan. Happy to be here and excited about changes to 855s and all these enrollment requirements we've got going on.
Well, and I think that you and I have been thinking about these in a very practical way since we're in the middle of a lot of different transactions right now. You and I recently did a podcast on consolidation through member substitution. So we have a lot of those going on. And so when these things came out, it was, trying to bring out how they might affect some of the things that we're working on currently. So this isn't sort of pontificating. It's actually, how do we navigate going forward? And I think that that's sort of, I know I feel fatigued by all these changes, and I'm sure everyone else does, because it's just the number of changes coming out.
Absolutely.
The pace, and then just, we used to have the hospice wage index rule, and that was the rulemaking, that we really focused on. And now it's like all these other rules coming out that have stuff that is impacting hospice, and then things that aren't, just in guidance. And so it's a lot to keep track of. And so I think our hope today for people listening is to break down these different changes. And many of them are in proposed format, but given the climate right now and, all of the sort of fallout that has happened since that New Yorker article, I don't think anyone's expecting these things won't be finalized as they're proposed. So, but it is important to note a lot of this is the proposed rule. So, Adam, we did a prior podcast with Ragini on the 36-month rule. So we're not going to get into that here, but that was something big of extending the 36-month rule to hospices. Mm-hmm. But I guess, tell me, as you sort of piece together all these different things coming out, what do you think the government's trying to accomplish? And, what's sort of the framing around all of this from your perspective?
Yeah, these are kind of flowing naturally from the same concern that the 36-month rule addresses, which is, mainly preventing flipping of hospices, kind of conducting transactions or changes of ownership in rapid sequence. And then more specifically within that, doing that without reporting those changes to the government. And so where the 36-month rule kind of places this temporal limitation on when you can do those things, all of these other rules are sort of coming in around that, saying, okay, short of or even in addition to those changes, if you're making changes in ownership or control of the hospices, we, CMS, want to know about it. You need to report it. And they're really getting into the weeds in how hospices are operated and who has control over the hospices. And this is all a result, it appears, from the concern about fraud going on in the hospice industry.
Well, and I think a backdrop to this, which I think we were getting wind of this from clients about this national site visits. So CMS has reported that it is completing a site visit of every single hospice in the country, which is now 5,000 something. And so we know that was done because I think, to your point, a lot of these concerns were there's hospices that are not operational. And so these site visits, this isn't survey stuff. It is just like, do you exist? Is there anyone here? Is this a legitimate business? And so we have that as a backdrop. They didn't need to do rulemaking to do those kinds of site visits. We also know, the 4-state focus in that December article has been Arizona, California, Nevada, and Texas. And then they announced enhanced oversight for those particular states, which we're not going to go into great depth on that. But, I don't think I've ever seen the government move so quickly in the matter of, we're not even at 9 months from the time of that article, but just a lot of changes. And as, Ragini and I talked about the 36-month rule. Many of these things were on the list of things that we as an industry suggested. So I don't think they're surprises, but I think it's just the pace is a lot to keep track of. But jumping into the meat of this, so we're going to be talking about the home health proposed rule, which was very long. And it came out, of course, on a Friday at like 4:00. I think, was this like 4th of July weekend or something like that? You're just sort of like, oh, God, and of course, like the pre-Federal Register version is always like, quadruple the pages because it's single space and all that stuff. But so there was a lot of hospice stuff in this home health rule. And that's what most of what we're going to talk about today is. So let's start unpacking what was in this rule. And well, maybe before we even do that, Adam, I think something that's come up in these transactions we've been working on is, what the attention that people are putting on enrollment is. I just think that maybe word to the wise, and we'll probably circle back to this again as a takeaway, but just really make sure your PACOS enrollment stuff is updated, and that when there are changes in board members and management employees and all those other things, separate and apart from any of these changes, you really need to make sure you're keeping your enrollment up to date, and don't wait till revalidation to do that. You really need to be making those changes when they're happening. Because I do think a lot of the things that we've experienced even before these rules came out is, I think the government is spending a lot more time looking at enrollment. And I think that there could be negative inferences if somehow you're not keeping your PACOS up to date, and like somehow are you trying to, hide something, which I don't think any of the situations we've dealt with, anyone's trying to hide something, but you are not keeping track of changes or notifying the government of changes that happened quite some time ago. I guess, I don't know if you want to add any color to that.
Yeah, they definitely are looking into it with more scrutiny, and that too is the general direction of all these new rules. And so, to contrast it with the 36-month rule, which is sort of easy to avoid by either not doing a transaction at all or maybe structuring a transaction a certain way. A lot of these changes are going to be implicated whether you're doing a transaction or not. In day-to-day management of a hospice, managing employees are going to turn over. And when they do, the information that you have reported to CMS will no longer be accurate. And in the context of the scrutiny we're seeing the government put into all these reporting requirements, kind of just in thinking through the implications of these rules, they do seem to be far-reaching and pretty significant for hospices.
I think that's a great point, is the things that we're talking about, like people who are in management of hospices need to know and understand. This isn't something we should just leave to compliance people or whoever in your organization, because just like I say, folks who work with patients on getting election forms signed, they oftentimes don't know and understand the importance of that document, right? So if there's blanks that are left or whatever, that person might not know what a linchpin that document is in terms of us getting paid. And I think the same thing with this enrollment stuff. It hasn't probably been something a CEO is really fretting about, and I'm not saying you need to fret, but I think that there needs to be more focus on this is really important stuff, because if you're not keeping things updated, as I said, that negative inference, like,
right,
are you trying to hide something or whatever? And so I just think word to the wise, the things we're talking about, exactly right. Everyone who's operating a hospice needs to know and understand these, because it's not just don't do a transaction and then I don't need to worry about this. So let's jump into these. So we have first, what do we want to talk about first here, Adam, about this enhanced oversight?
Yeah, well, you had mentioned in the introduction the 4 specific states that were targeted: Arizona, California, Nevada, and Texas for this enhanced oversight for new provider enrollments. And this was announced previously, but this general concept of enhanced oversight and prepayment review was included in the home health proposed rule for hospices. And so to date, we haven't seen it applied to hospices in other states, and the focus has only been those 4. This prepayment review may be applied to other states and other hospices as well.
So, but the 4-state review it's already in effect, July 13th. And this enhanced oversight is sort of a new provider review kind of thing. So if you're brand new to Medicare, you are going to get some type of prepayment review, right?
Right. Yep.
And so that's, I feel like in talking to clients, I would always say you're going to get prepayment review and whatever. But I think the new thing here was about if there's change in ownership or change of information, and I want to break that down a little bit, that you will also get prepayment review. And that's sort of getting at the concern is you have some hospice who, passes accreditation, doesn't ever submit a claim, then there's a change of information or whatever. And then that new provider who bought that isn't going to be considered a new provider, right? Because they're assuming that Medicare provider number, they wouldn't be, put into a prepayment review. But this is actually saying, even if you're, coming to Medicare and you've assumed a Medicare provider number, you're still going to be subject to prepayment review, right, Adam?
Right. Yep. And it applies. So like you were saying, not just to new enrollees, but also those undergoing a change of ownership. And also 100% of ownership through another means, so a change of information. So these 2 categories would be, what you would typically think of as an asset purchase for a change of ownership, where traditionally the tax ID associated with the provider agreement would change, but also transactions that wouldn't be classified as a change of ownership. So an equity deal where the tax ID may be staying the same, but the ownership will change. And so the threshold they've set for changes of information based on ownership is 100%. So it's unlike the 36-month rule, which addresses 51% or more. This requires 100% change in equity, but is still expanded beyond the change of ownership category.
Yeah. Well, and we've done other podcasts on the difference between a chow and a choy, and it can be very confusing. But I think that the takeaway here is if there is a transaction and you're assuming, ownership, no matter sort of how that deal is structured, you're likely going to have prepayment review. So, I think diligence has always been really important in deals, but like there's going to be no breathing room. Like you are going to be immediately probably getting prepayment review, and that's going to immediately have a cash flow issue, right? And stuff. So, I think that's something for folks to be prepared of, and that could sometimes impact transactions where, there's member substitution, right, Adam?
Yes, particularly under this final prong of the change of ownership and control, where you may be kind of creating a new sole member that would be reported on your 855 as the managing or controlling entity. That would trigger this type of a review as well.
So I think listeners out there who, just because you're a nonprofit and, it's not really like a change of ownership, right? Because it's just like they're coming under our umbrella, this might, impact you as well. again, it doesn't mean that you're not going to get paid or anything like that, but it's just in terms of, I always talk about what's the runway ahead look like when you're doing this and when we're advising clients, is to just be prepared, right? That this is going to be a thing. And it's like, you're going to have TPEs like out of the gates, right? So,
and structuring transactions, knowing and anticipating some kind of a cash flow issue. So whether that's with an escrow concept or a working capital concept in the purchase agreement, is to make sure a buyer has capital on hand, maybe more than you would anticipate otherwise, because of those cash flow disruptions.
No, good point. Good point. So then let's talk about this screening. So with, and we're going to be talking about Medicare here, but I think state Medicaid programs can have their own screening. And this is about how high risk certain provider types are viewed, because, you know, there can be different hoops you have to jump through in terms of how long this might take to process, or what hoops I have to jump through, depending on my risk for what I think let's just call fraud, right? So hospice got moved to high risk. Is that right, Adam?
Yes, that's right. And so practically speaking, in terms of the additional screening hospices can expect, they are now required to submit fingerprints for anyone with a 5% or greater direct or indirect ownership interest. And then those individuals will be subject to a national background check.
Okay. And I know in talking to some clients, they're like, we already do this. Yeah. So it wasn't a big deal. And this talks about, so brand new enrollment. So people listening are like, I'm already a hospice. This isn't a big deal. I don't need to worry about this. But then there is this, and any new owner. Let's explore that a little bit more about what is considered an owner and stuff. Why don't you break that down a bit more?
Yeah. The owner includes both a direct and indirect ownership interest with a threshold of 5%. And so this could be, for example, a direct owner, so an individual that has an ownership interest in the hospice itself. But by including indirect owners, they're also including those owners of holding companies. So any individual far up the chain, or however related to the hospice, if they have an ownership interest of 5% or more, they'll have to submit these fingerprints and background check. And so, you know, one of the issues discussed often is the increase in private equity in these transactions. We know kind of from the structures of those transactions, you see a lot more holding companies, a lot more complicated structures. And so you can anticipate this to impact those types of purchases in the private equity world pretty heavily.
Yeah. So as you're talking about this stuff, Adam, and we're talking about choice and chows, and then we're talking about direct and indirect and all these percentages. I mean, I think that, again, people didn't spend a lot of time thinking about, am I doing enrollment right? Right. You know, and what do I have to report, and understanding what these definitions are, not just the timing, but like the who, right? Like the 5% of who, you know, and exactly. So I think that these are actually going to become more legal issues than maybe ever before, because I think all this enrollment stuff and what you need to report and when and who and all this stuff maybe is going to get more complicated. And I think, you know, probably talking with counsel is going to be more important, because I think most of the time to date, most people don't. The only time we're dealing with enrollment issues is in transactions. But I mean, I do think in terms of when do you need to update and your 855, which we're going to talk about sort of now, I do think that, you know, there can be a role, like you might want to cross-check stuff with counsel sometimes to just make sure you're doing things right, because this stuff is not intuitive. It is like change of ownership means one thing, like from a corporate standpoint, which can mean a very different thing for CMS. And so I don't think it's like, these are not like a lay person's understanding of what direct and indirect is not what the government necessarily thinks those terms mean. So
they're not aiming for an intuitive definition, I don't think. But yeah, that's a great point. Especially as org charts get more sophisticated, identifying the direct and indirect interests can get complicated, but really identifying the percentage of interest and calculating that out can get quite complicated too.
Yeah. All right. So then let's talk about 855 stuff. And we've mentioned on other podcasts the affiliations rule that came out now a number of years ago, and that this was to sort of, again, in line with some of the stuff we were talking about, and it wasn't focused on hospice in particular, but more transparency around who are these, companies that are owning healthcare organizations, and are they behind lots of other healthcare organizations and all this stuff. And so that rule hasn't sort of been fully implemented because there needed to be infrastructure around how you report these things and stuff like that. But let's talk about these 855 updates. Now, these are, again, coming out of the home health rule, right, Adam?
Right. Yes.
So why didn't you check these off about what are new things in the 855?
Yep. So one is the addition of a checkbox to identify whether the provider is owned by an organization or not. And so the concept of reporting an owning or controlling organization is not a new concept. You're already required to report that, but the checkbox has not been there. So talking about the complexity of reporting corporate owners, I think this is another way of just making people, first of all, make an affirmative statement, yes or no, and then getting them to think through it at a granular level. Who their owners really are.
Just as you say, the checkbox and making an affirmative statement, sort of this idea of like, and I don't want to plant seeds here, but how can enrollment, and you make statements that are inaccurate on your enrollment form, right? And you've made representations that are inaccurate. How can that be used against you later? And so I think all word to the wise, like these documents are really important because they're going to ask you, well, you represented X on this, right? And then that becomes inaccurate. And again, there's human error in the world. I mean, I think things happen, but again, I think there's going to always be like a negative inference, like, well, you didn't disclose something because you didn't want to disclose it because you're really trying to hide something, as opposed to I was very confused by this form, or I overlooked it, or, whatever. So,
right.
So I think it's like the checkbox isn't a big deal, but in general, what is this representing? I think what you said about making, affirmative statements about representations about things.
Yeah, there's an attestation at the end of the form for a reason, and they take this seriously. So even though a checkbox may seem kind of innocuous, with the scrutiny we're seeing, it's definitely worth paying attention to.
Yeah. So what else do we have?
We also have a new disclosure of whether or not the provider is owned by private equity or a real estate investment trust. And these are two new categories that we haven't seen before. And so, again, these are categories that I think CMS is particularly concerned with in terms of why hospices are being bought and sold. And how that can affect not just fraud, but also patient care.
Yeah. Well, and I think that, CMS is concerned about it. The Department of Justice has, also indicated concerns about, private equity and accountability and things like that. And so I think you have lots of different parts of the government interested in that. So this isn't really a surprise that they now are affirmatively asking about that. And 20 years ago, that wasn't a thing. So of course it's not going to be on the form. But and then this next change I think is really important because this is, again, something everyone needs to fill out, and that's the definition about managing employees. So on the 855, isn't it like section 6 or something where you have to list managing employees?
Yes.
And again, this is something that it's not always clear, like, well, who is a managing employee? There are some clarifications they made about managing employees. So why don't you talk about those?
Yeah. So like you said, the managing employee is someone you have to disclose on the 855A. And so this proposed rule changes the definition of managing employee in the regulations to include a medical director or like a CMO, but they expressly use the term medical director. And so, in general, the concept and definition for a managing employee to date has been someone who has operational control over the organization and exercises day-to-day management and administrative control. And so in the past, in thinking through, who you have to disclose to be responsive to that definition, the medical directors are, sort of a gray area depending on their specific job descriptions, job duties, what they're doing for the hospice, particularly since, oftentimes they're obviously more involved in the clinical aspect of things as opposed to the administrative side. So this definition clarifies managing employees and includes medical directors. So moving forward, the medical directors are someone hospices will have to disclose to the government. And I think, circling back to the beginning of the conversation and really the whole conversation about the importance of keeping your enrollment up to date, this is a position where, as opposed to maybe a CEO, you might expect a little higher turnover rate. And so, some providers may have a disinclination to report employees where you expect a high turnover rate with the expectation that if you report them, you also have to update them. This proposed rule now makes clear that medical directors do have to be disclosed.
And this is, again, different rule, but the hospice wage index now requires, certifying physicians to be enrolled in Medicare or have been, filed for an exemption or whatever. And so I'm not surprised by this change, right? Because it's like physicians play such a huge role. They are the gatekeepers, and understanding, right, their background and who they are. And then is someone a medical director at like 20 hospices? Is that really possible, right? What are you doing and stuff? And so I think there's going to be, pulling back the curtain a little bit more, because I think from a licensing perspective, I think oftentimes you don't need to report medical directors either. So this is something that will be a different change. And again, it will be interesting to see what comes out of all this stuff, right? Because the point of this is we want to know this information and are going to create an affirmative obligation for you to tell us. But then it's not going to stop with just like, oh, you reported it, right? They're going to data mine that, and there's going to be, stuff that they're going to do with this information. But if they don't create obligations to report things, it's hard for them to then make connections and do all this data analytics stuff. So, I think that plays into a bigger, scheme of things in terms of how the government might connect certain dots and whatnot. So,
the commentary also points out that this is not kind of establishing a floor to who you have to report. I think on the contrary, expanding the definition to medical director really just points our attention to this clinical side of operations, maybe that also should be reported. But at the end of the day, you've got to look at not just the title, but the roles these people are performing. So thinking through, why did CMS make this change? We kind of have to think through at a broader level, what are they concerned about? What does this indicate about how they're going to interpret the definition? And so one thing that can be sort of a painful but fruitful exercise to do with clients is to think through what is your specific management structure? What are the titles, but also what do they actually do? Because you may call somebody a CMO or an administrator that, even if the term isn't expressly included in the definition, is someone that should be reported or that CMS may consider a medical director. And you also mentioned state reporting requirements, which is something else to consider. What have you reported to the state? What have you reported to CMS? And are those matching up?
Yeah, I think that's a really good way to think about it. Like, this is indicative of a signal of how we interpret operational control, right? Even though people would say, I don't have any power, right? I can't do anything. And then it's like, but not really, right? So, but anyway, I guess anything else before we talk about deactivation?
No, I think that's all I had on that. Just emphasizing really, really understanding and looking through who your employees are and what their job duties are.
So then, something that there was a big spotlight on was people who got Medicare provider numbers and then never billed anything. And so the law had already allowed them, essentially, if you're not using your number, that can be considered, a voluntary termination or something like that. And so tell me what they did in this proposed rule. They're shortening it to if you haven't billed in 6 months.
Yep, they're shortening it from 12 months to 6 months of non-billing for when they can deactivate a provider number. And so it was, and until the proposed rule goes into effect, a 12-month period. For a long time, we didn't see any enforcement around deactivation for lack of billing. All of a sudden, we start seeing this type of activity, deactivations for non-billing. And right on the heels of that activity, no surprise, we see this shortening from 12 months to 6 months. And so, really just cracking down on having these extra numbers. And the intent is, again, to prevent fraud. And so the worry is you have one number that you're operating under and keep another number kind of on the side in case anything comes up, in case you have a big overpayment. And then you just switch everything to this other number. And the official term used in the commentary is whack-a-mole arrangements. So I think this is the first time whack-a-mole has entered official discourse, but it's there now, hopefully to stay.
Oh, that's hilarious. Well, and you and I have had to deal with some deactivations recently that, it wasn't fraud related, but because we had a client that hadn't used a Part B number for a number of years for their palliative program because of, just with COVID and being stretched for resources and, but then suddenly they get a notice. And I mean, typically it hasn't been a problem to get reactivated. I mean, it's obviously somewhat of a burden, but, I think potentially in other situations, maybe it could be more difficult to get reactivated, and people are probably like, when is this going to stop? We're on number 6 now or 7 of these changes, but there are a lot. And we're going to link to the rule so people have that. And this podcast is longer than many of ours just because there's just a lot here and a lot to for us to take in. But I also think sort of breaking it down for folks, because this isn't I don't need to worry about this because I'm not a fraudster. This is going to impact every single hospice in the country, a lot of these changes. So all right. So then we have expansion of the reapplication bar from 3 years to 10 years. What's that about?
So this is for providers who are terminated or revoked because of adverse final events like an exclusion or felony conviction, involuntary terminations, that kind of thing, expanding it from 3 years to 10 years, the time period you have to wait before you can reapply to participate in the Medicare program.
Yeah. Hopefully most people don't need to worry about that, right?
Yeah, hopefully not.
It is in there. And then, everything we've been focusing on is really about in this home health proposed rule, but there was also the physician fee schedule, which is very, very long. And there was some changes in there that we just want to touch upon. One was about like prior notification of changes in practice location, right? And
right.
This rule wasn't specific to hospice, it was just general. And we've had some questions from clients about this, and I don't see this as being very impactful for hospices, just because the hospice regulations already require prior notice or prior approval of multiple locations and changes in your primary practice location. This isn't necessarily new, but there was other things like reporting misdemeanors, right, Adam? And wasn't there one more thing too?
Yeah, civil judgments under the False Claims Act and the consequences of failures to repay debts to the government.
And that, I think, is a really important one because, there have been over the last decade or so in terms of hospice, some notable cases that have been in the media about, someone had some big cap liability or some overpayment to the government, and then they just close down and then they restart again. And now, with this change, that actually could be much more impactful, because it isn't just like, we send it to U.S. Treasury and then they don't collect it and you're fine. It can actually mean like your ability to get back in. And why don't you talk about that a little bit? Could be hampered, your ability to get back in. And
yeah, exactly. And this kind of works in conjunction with the rest of the rules too, in terms of reporting owners, who they are individually. And you mentioned the affiliations rule, that is also the type of behavior that the affiliations rule is geared at preventing and allowing CMS the ability to determine, who has been subject to these debts, hasn't repaid, and maybe trying to get back into the program as well. Now it's not just an EIN and a legal business name. They're going to be kind of giving more attention to individual owners.
Yeah. So I think we finished our long list. Because you always have to keep me on track of which rule is that again. And it's like, it just is. I feel like I know what they're doing, but it's just like all of the different rules and then the MLN matters. And it's just like coming at every single direction. Yeah. But I think the bottom line that I see here for folks is I really think 855 stuff and what you're reporting to the government is incredibly important. And if I'm a C-suite kind of person, I didn't probably spend much time thinking about this, but actually I think you want to understand this a little bit better so you can make sure that, your 855s, which most likely the CEO is signing, are accurate, right? Because, and that people, and because sometimes, it's compliance, but sometimes it's even a step down of who's filling out these 855s. Like it could maybe be a lower level administrative person. And it's like, they're doing their best, but like they didn't listen to this podcast and talk about this, or maybe see the nuance there. And so I think it's just, there's got to be, if I were a CEO, I'd want to make sure my organization is really doing this right, because I'm going to have to sign this, and I'm the one that's signing in blood there that this stuff is accurate. And like humans make mistakes. That's not, what the government's really focused on here, but you want to be able to make sure we're trying our best. And so if that's like, we review monthly at whatever meeting we have, are there any changes that we need to report on the 855? Do we have any new board members? Do we have any new such and such? It just building it in so it's not like it's revalidation time, which comes like every 3 years. Let's make sure we get things updated. And it's like, absolutely not, right? Like you need to do this on a real time sort of basis. So I think it doesn't have to be rocket science, but I think that making this more part of routine conversations on a regular basis, just like, right, we screen for exclusion every month, right? Mm-hmm. People put that. I mean, it's making a system around this. And then obviously, if there's concerns about how to interpret managing employees or some of these more nuanced things, then you can reach out to counsel and talk about those things. But if we don't have a forum in which to, at least ask the question, I just think it's going to because this is not exciting stuff. No one's like, woohoo, this is really fun. This is a, strategic insight I'm providing, but like incredibly important because we know the government's doing these things because they really want to get a better understanding of what's going on and go after people, right? And create accountability and all the stuff. So, I think it's not the exciting stuff of healthcare. It's not the innovation, but this kind of stuff really matters.
Yep, exactly. It's important and it's going to become part of operations or ought to.
Yeah, it sounds like there's a lot of not fun things about, healthcare. And I think there's lots of exciting things going on right now in terms of, value-based care and new opportunities and stuff. And so, but we can't lose sight of sort of these nuts and bolts and making sure that someone who's really up to date is supervising this 855 stuff. And you're not saying this isn't an exciting task, so I'm going to go give it to someone low on the totem pole, because that is a recipe for disaster, because this is actually becoming a more and more sophisticated and important part of staying in good graces with the government.
Yep.
So,
exactly.
We got to do our next podcast on something exciting and innovative.
Yeah.
But instead of 45 minutes of here are like 800 new rules to comply with. But anyway, well, thanks for digging into these, Adam. This was
absolutely,
and for keeping me on track with. I'm sure tomorrow I'll ask you again. Where is that? When did that? Is that the physician fee schedules?
I'll refer you to our podcast.
Yeah, exactly.
Gotta get those listener numbers up.
Yeah.
Especially for this one.
Yeah. I got amnesia over that. So anyway, well, thanks a lot for your time. And I think this was a great episode. Very important, even if not, exciting, it is very important. So thanks for taking the time.
Yeah. Thank you for having me.
Well, that's it for today's episode of Hospice Insights, The Law and Beyond. Thank you for joining the conversation. To subscribe to our podcast, visit our website at hushblackwell.com or sign up wherever you get your podcasts. Until next time, may the wind be at your back.